Thank you for the very kind invitation today. I would like to share some evidence that data sharing is not bad, and actually it's pretty good, although there may be some caveats. Some conflicts. I'm funded by NIH, Stanford University, and non-for-profit foundations. I have no financial conflicts with for-profit organizations.
Is your mic on? And to push the button to the red light.
It was on. How about now? Okay. So what for? Why do we want to share data? I think that there's basically three major types of endeavors. One is standardized integration of data from multiple clinical trials. The second would be reanalysis, confirmation or validation of original results. And the third would be extended analysis that go beyond what was originally conveyed in the literature or in the scientific community or to the public. So how about standardizing integration of information? Do we have any example of any field that underwent a transformation from single studies done by single teams, it could be multi-center teams, siloed, publishing lots of discoveries, not data sharing, and then switching to data sharing all the time and joining forces and meta-analysis with integrated standardized information? This is human genome epidemiology. When we did that transformation and when we had that paradigm shift, how much of what we thought we knew before got validated? We have the answer empirically because that new wave of data sharing and integration and consortium level analysis, with practically all the big analysis done in consortia and lots of that also having public data sharing, we could test to see what had happened in the past. Replication rate for our previous knowledge, 1.2%. We also learned a lot. We learned about 5,000 gene effects that we had no clue about and we had no chance of getting with single studies done by isolated investigators. RCTs are different. Yes, first of all, they're randomized. Then we're talking about big effects. Not really. On the left panel, this is data from about 220,000 randomized trials that we have analyzed in 85,000 meta-analysis, asking the question, are there very big treatment effects? The answer is no. Almost never. There are treatment effects. There's thousands of interventions that work, but they work a little bit, which means that we have to take care of the noise. If the signal is within the noise range, then we are really stuck. Second problem on the right panel, it's the rare exception that a single randomized trial or a set of trials on the same intervention by the same drug, by the same company, will be the answer that we want for medical care, for practice, for physicians, for patients, for public, or even for the company. Why is that? Because for most situations currently, we have lots of competing interventions. These are networks of treatment comparisons for different medical fields. Typically, we have anywhere from a few different drugs up to several dozens that would compete with subtle differences, subtle effects, sometimes subtle differences also against placebo or no treatment. And usually we have anywhere from a few trials up to thousands of trials. And the only way to get a reliable answer is really to piece all of that evidence together. Who's going to do that? Well, some meta-analyst is going to do that, like the systematic review that Peter showed in Lancet showing that it is effective. Well, if we do that, we practically piece together all that fragmented, selectively reported, selectively analyzed information, and who knows what we get. Probably not very reliable information. Another myth. Randomization protects analysis. And once you have data from a randomized trial, there's only one way that you can get one result. That's not true. Here's an empirical evaluation looking at 200 trials published in the highest impact factor clinical journals that publish randomized trials. We asked a simple question. Do people adjust their analysis? Shouldn't make a big difference. These are randomized trials. So first of all, we couldn't find that information on the web or publicly anywhere available. Only 2 of the 200 trials in these major journals had that information available. So we asked the investigators, and 60 of them gave that protocol with the analysis plan that we could see what was their protocol and analysis plan. Guess what? 50% of the time, the analysis plan and the protocol was different compared to what had been published in these major journals. These are the best trials in the best journals by the best and most transparent investigators who are willing to share that information with us. Does it make a difference? Well, about 20% of the time, when a reported analysis is shown both with adjustment and without adjustment, One is nominally significant, the other is not. Guess what? What is the interpretation of the results in these cases? Almost always favoring the significant results over the non-significant results. So randomized trials could have a lot of what I call vibration of effects. The notion that there is a single effect, a single result, a single analysis, and nothing else is really very misleading. It would be very nice to be so. It would be very nice that it would be specified and agreed, and there would be consensus and standardization that that would be the case. If it's not, and the vast majority of cases this is not what has happened, there's a lot of leeway of getting very different results. This is volcano plots looking at an observational study. This is NHANES, the National Household Survey. And what I've done here with Chirag Patel and Belinda Burford, we said, why don't we analyze associations of different risk factors with mortality? And many of these risk factors actually are things that could be studied in randomized trials. For example, the one on the right, far right, is vitamin E. Lots of randomized trials on that and lots of epidemiological studies on that. But you know what? We'll analyze it in every possible way that we can think of. And it's very easy to come up with about 1 million different ways to analyze the data just by adjusting or not adjusting for different factors. The plots show p-values and effect sizes. In many cases, like the ones in the far right, you can get a highly protective effect and a highly detrimental effect, significant in one direction, significant in the other direction. This is just playing with a few adjustments and no more than that. How big is the vibration of effects in clinical trials? I think it could be substantial. How do we know? Well, there are some reanalyses that have been done. Even in our world that has so restricted access to information, we found empirically 143 papers that were reanalysis of raw data from randomized controlled trials published in the literature. And this is what they look like, the original articles and the reanalysis. A couple of interesting observations. First of all, almost always, about 80% of the time, the reanalysis involve authors from the original studies. It's the rare exception that someone completely independent has taken these data without having any involvement of the original authors. But there are a few cases, and then one has either public availability of data, or it could be some approval that they got in 9 cases, or in 6 it was completely public access. Most of the time, people didn't look at the same analysis. They looked at different analyses. But when they looked at the same analysis, and I remind you that these are really the same people, most of the time doing these analyses, they followed all these different ways of analyzing the data. I'm not going to run through the list. It's really many different ways that one could reanalyze the same data. And when they did different analysis, this is what they did. Subgroup analysis, predictive analysis, different outcomes analyzed, differences in eligibility criteria, only data from one arm analyzed, or things like that. Didn't make a difference. It did. About a third of the time, the conclusions on who are the patients who should be treated were different based on the reanalysis of the evidence. So to me, I think that we have a brave new world. There's lots of data out there. I think that in order to trust what they stand for and to make the best use of them, we need to have access to them. How to do that? I think this is why we're here. Thank you.